Hello, everyone. Welcome to another Rafael Medina subspecialty VMR that we have on Monday. Today, we are really excited to have a long time here helping us on VMRs, Dr. Daniel Restrepo. He always participates here with us on clinical reasoning, and he presented like amazing case on our POCUS VMR. So we are really happy to have you here. And do you want to introduce yourself?
Hi, everybody. My name is Dan Restrepo. I am originally from Colombia, but have been in the United States for about 20 something years. I am a hospitalist and internal medicine doc in Boston, Massachusetts at Massachusetts General Hospital, where I am one of the associate program directors and one of the core teaching faculty members for the Department of Medicine and the internal medicine residency. And I'm super excited to be here. Just to take a moment to say this is the first one I've done without Rafa, and that his smile is missed, but I know that he's with us, and that this one goes out to him just because he was such a shining light.
Oh, thank you so much. I think we all miss him, and I think it's been like 3 months without him. So I always feel that something's missing, but we're trying to keep his legacy. So we have a question for you that Youssef wants to make for you. That's why people should join hospital medicine.
So when I was going through my training, I loved internal medicine. I loved the breadth. But I mean, all my mentors were generalists, and they were people that were just medicine docs. They were like internists, and they couldn't, they were consummate diagnosticians, and they were patient-centered clinicians and bedside diagnosticians, and that was always sort of like kind of who I wanted to be when I grew up, and like diagnosis was always my infatuation in medicine. And so, I thought about kind of all subspecialties of internal medicine diagnosed, but really when it came to it, it was practicing general internal medicine in the hospital, being a hospitalist, it kind of combined the acuity of the inpatient setting, the ability to kind of iteratively test hypotheses in real time, and having quick turnaround was always like incredibly sort of it just like I fell in love with it. And and ultimately, like, as a if I forget to ask a question, I can like run back, and like my patient is like captive there, and I can go ask them that same question. So to me, it checked all the boxes. And like every time I thought I wanted to do ID, then I realized I would miss nephrology, and then when I wanted to do nephrology, I realized I would miss hepatology, and like eventually that's just called internal medicine. And like then people say like, oh well, there's the ICU, and that's like hospital medicine, but like on steroids. But like for me, it was the art of the story and the art of the exam. Like I found for me, oftentimes kind of like took a back seat when folks were just so sick in the ICU. And to me, that was like, it was the sweet spot. It was acute, but it wasn't like, crazy, everything's on fire acute. And it was diagnosed to the purest. And I will say this, I don't think that there's any place better, me personally, to teach as an educator than on the wards. Teaching at the bedside, you get to go back, you get to spend more time there. There's not like the pace of clinic. So that's why I have like that's a really long answer, but that's why I picked it.
Thank you so much for your answer. I think can help a lot of us here to decide what we are gonna do. And we like to ask like what you like to do for fun outside of medicine.
I've been traveling a lot, so I just went to France for the first time, which was really, really awesome, and kind of hard not to fall in love with France. So that's what I've been doing for fun recently.
That's amazing. So I think we should start. Like, Ricardo, can you share the screen, please? Mark, when you want to start with the case, we are ready.
Sounds great. All right, so our patient, so we have a 38-year-old female, no known past medical history, who presents with 2 to 3 weeks of fevers, headaches, cough, arthralgias, and myalgias.
All right. That's a lot of symptoms. So we have a 38-year-old woman. At this point in time, we think that she's presumably healthy. We may unearth sort of additional kind of modifiers of her health as we kind of talk more about the case, and we may unearth a little bit more within that bucket of like substrate and problem representation. But we'll start by kind of voicing that this is a presumably immunocompetent woman presenting with an acute to subacute sort of constitutional syndrome characterized by fever, cough, arthralgias, myalgias. So at face value, the first thing that kind of just pops out of my head is a viral illness, right? She's young, she's presumably healthy, but the 2 to 3 weeks, that 3-week mark is starting to make a traditional viral infection seem a little bit out of the realm of ordinary. Whenever you hear fever and a headache in the same sentence, it makes us medicine docs a little terrified, because the most sinister thing that kind of comes to mind would be obviously meningitis or encephalitis. The thing that makes actually this a little bit hard to tease out is that most people with fevers will get headaches, or most people with viral illnesses will get headaches. Anybody who coughs hard enough for long enough will end up with a headache. And so it's really, I think, important to tease out whether or not the headache is at the center point of the syndrome, where it was like, this is truly like cephalgia, this is like headache, oh, and also I had a fever and all these other things, or it's like, oh crap, I got hit by a ton of bricks, and also, you know, there's just, I do have a headache because I've been coughing my brains out, and, you know, it just hurts to even cough at this point in time. With arthralgias, myalgias, again, infections really do come up. Myalgias in general tend to be sort of often seen, especially in febrile syndromes, in the presence of kind of like evil humors and cytokines, and I don't actually know why it makes muscles hurt that much, but any sort of pathogenemia, so viremia or bacteremia, can often give you this entire kind of constellation of joint pains and myalgias. Whenever we're thinking about fevers, obviously we're thinking about infectious causes, which we'll talk, I think, a lot more about. The tempo here with the 2 to 3 weeks could suggest, again, a host of infections or a variety of infections. I think when we think about what infections are possible, it's super important to think about the host, and hopefully we'll learn a little bit more about this, right? Because if the host is abnormal because of anatomy or immune competence or travel or, you know, epi or medications, then the list of possibilities starts to widen. And you think about, you know, things like traditional bacterial and viral, but then you bring up the idea of possible fungal infections, the idea of parasitic infections, tick-borne stuff. Hopefully we'll learn a little bit more about her as a host and get a really good social history. And then we think about kind of sterile causes of fevers. And the 2 most common things on that list would be autoimmune disease. She's a young woman, so certainly something to keep in the back of our heads. Malignancy seems rather acute for a malignant fever. Most people with tumor fevers, which are typically caused by liquid tumors like lymphoma and leukemia, but sometimes if the tumors have liver mets or if you have large amounts of disease, can cause this. But they're usually, people often don't like point to right when their fever started with tumor fevers. Other weirder things, drugs, clot, endocrinopathies, you know, all of these things are on the list. Obviously, this is an incredibly wide differential diagnosis. Again, cough, arthralgia, myalgia, you know, and the duration with the headaches, it really does make me think of an infection first and foremost, but not going to commit all the way quite yet. I want to learn about her as a host. I want to learn about her social history. I want to learn about, you know, like travel history, substance use history, sick contacts, lots of different things, medications, supplements if she doesn't, you know, take any prescribed medications, all that good stuff. But I'll pause there for now.
Amazing. Yeah, and Mark, if you can give us more information, please.
Yeah, such a rich discussion. And I'm just gonna say that I'm gonna say very authentic to this case. This patient first presented to a neighboring hospital, and then I first took care of this patient my first day in the ICU as an intern. So I'm just gonna say the neighboring hospital course, and then go from there. So the patient essentially presented to the neighboring hospital, found to have a fever to 104, but other vital signs were stable. She originally got some imaging that included a
Sorry, Mark, that
CTG.
includes a heart rate, like not tachycardic on presentation?
Yeah, not tachycardic on presentation. Sorry about that. Yeah. Blood pressure was stable, heart rate was stable, sat in long room air, but was febrile to 104. She got a CTPE that showed no PE, but did show prominent bilateral hilar and mediastinal lymphadenopathy. And then she also got a CT abdomen pelvis that showed hepatosplenomegaly. So the neighboring hospital started broad sepsis antibiotics, that being vancomycin and piperacillin and tazobactam. And then really just throughout the hospitalization, the patient continued to get worse, had worsening cough, worsening dyspnea, and then developed hypoxemia on hospital day 7. And the neighboring hospital got a repeat CT chest that showed progressive widespread bilateral airspace opacities and new bilateral effusions. She continued to fever. And then the next day after she got that CT scan, it was hypoxemic. She became acutely confused. So the outside hospital got a lumbar puncture, which showed a white blood cell count of 291 with 78% lymphocytes, a glucose of 38, and a protein of 190. And then her antibiotics at that time were broadened to vancomycin, ceftriaxone, ampicillin, doxycycline, and azithromycin. And then unfortunately, after the lumbar puncture, she developed worsening respiratory distress and acute hypoxemic respiratory failure, requiring intubation, and then shock requiring vasopressors. And the last thing I'll say, I know this is a very, a lot of data in this aliquot, but she also developed pancytopenia and worsening renal failure throughout her hospitalization. And on day 10 of the neighboring hospital hospitalization, she was transferred to our ICU for further management. And that's the end of that aliquot.
Well, wow. I guess first off, like she's sick as stink. And maybe in broad strokes, she is getting worse, being treated for typical bacterial pathogens. So that, I guess that would be the summation, right? What are we missing here in terms of, she developed multiple organ system failure on vancomycin and pip/tazo. Now, you'd wonder whether the acute renal failure could be at least partly because of sort of issues with the combination of vancomycin and piperacillin and tazobactam. Some people will question that association. So that's possible, or this is the alternative, is that this is an antibiotic resistant multi-organ syndrome that is sort of causing progressive brain, respiratory, renal, and what else did I miss? Failure, all of the failures. So I think she's super duper sick. I guess we'll maybe start from the top and work our way down. So the reason 104 is really high. 104 is pretty darn high. If this was bacterial sepsis in a healthy person that's not beta blocked, bacterial sepsis should give you a heart rate response. Now there's a formula, I don't know it, but just gut, kind of passing the gut test. If your temperature is up to 104 Fahrenheit, which what is that in Celsius? It's well over 40, I think. You should have tachycardia, and she doesn't. So does that mean that this is a typical bacterial infection? No. It doesn't really argue for that very strongly. Again, if somebody's beta blocked or they have a bad heart, like in theory, that's possible. But a 38-year-old otherwise should be really mounting a heart rate. Does this mean it's not any infection? Well, no, actually, it can mean that there are sort of intracellular pathogens that are known for their fever tachycardia dissociation. So something like typhoid is your classical case of this. So I think her travel history will be super important here. But one thing to point out is that other intracellular pathogens like Legionella, other things like Leptospira, other things like just any intracellular pathogen, even viruses, can give you this sort of fever tachycardia dissociation. However, she has something that really, in an immune, relative quote unquote immune competent person, suggests some chronicity to this. And this is sort of something that is involving the reticuloendothelial system. So you have nodes and spleen and liver that are enlarged, and then you have pancytopenia, which means that this is now involving bone marrow, liver, spleen, and lymph nodes. So are there infections that have a predilection for the reticuloendothelial system? Sure thing. Tick-borne infections. They can also give you that fever, tachycardia, dissociation. I believe, Mark, you're in Philly, so there's not so much tick-borne disease as there is up in here in New England. But so things like anaplasma and babesia are certainly still possible. Eventually, some of these would be partly treated, at least with doxycycline. It sounds like she got worse on the doxy as well. And then the travel history, for leptospira and for things like typhoid will be important, but it may not yield much in the way of fruition. The other things to really think about here is that this is starting to behave a lot more like HLH, so hemophagocytic lymphohistiocytosis, right? She has her reticuloendothelial system is down. Were her aminotransferases up at this point?
I'll get into that, but she did have some hepatocellular liver injury as well.
Okay, so we have pancytopenia, we have fever, we have altered mental status, we have organomegaly. This is sort of starting to behave like really, really bad HLH as one thing to think about. Now, there are infections that can trigger HLH, but I already kind of beat those infections to death. So I think it's worth thinking about two other disease processes, which would be autoimmune diseases. So classically associated with something like macrophage activation syndrome, which is really due to adult onset Still's disease, or things like lupus. And then the other thing that can behave exactly like this is lymphoma, an aggressive intravascular lymphoma or diffuse large cell lymphoma. All of those things I think are very much in play right now. What I'm starting to believe this is not is a regular run-of-the-mill bacterial infection. Again, host would help us kind of pinpoint some other infections that could maybe still be in play, but time and acuity and the fact that she's refractory to all of these different therapies makes me start to lean at least away from typical bacterial sepsis. That was a lot of information.
Amazing. Yeah. Mark, do you want to give more information for us?
Yeah, I really wish I had you with me on my first day in the ICU as an intern. That was great. I'm sorry that I presented so much data, but I just really wanted to compact this in the best way possible. So next is the background data. So like I said, no known past medical history, no prior surgeries. She wasn't on any medication or allergies. She had no known family history of autoimmune disease, lung disease, and now into her social history. So she's from Nicaragua. She immigrated from Nicaragua to the US 8 months prior to admission. And she spent 2 months in Texas and was in Pennsylvania for 6 months. And she currently worked on a turkey farm before she got sick. And her husband noted that during her immigration to the US, she slept many nights outdoors. And her husband also noted possible animal and bug bites, especially rats. And she denied any alcohol or drug use. And that's the end of this aliquot.
All right. So remember how I said, before we married all those other autoimmune and the host is going to matter. This is like an ID doctor's like field day in terms of exposure history. And so there are infectious processes that can give you reticuloendothelial system involvement, that can give you lymphocytic meningitis, that can give you respiratory failure, that can give you all of those things. And sort of if we track her migration history and her exposures, we can actually probably learn a lot of clues as to other non-typical bacterial pathogens that could be causing this. The two that first come to mind when you tell me that she's from Central America and went by way of Texas that present syndromically pretty much identically would be tuberculosis and histoplasma. So my mentor, whom I hope watches this at some point, always says, anything TB can do, histo can do better. So always worth, whenever you're thinking about TB, think about the dimorphic fungi and think about specifically endemic and ubiquitous mycoses. And so an endemic mycosis that could behave like this, that she's been exposed to, would be histoplasma. The others being like, blasto or coccidioides, all these other are probably not in the right epi, but histo lives in Central America, and histo is also found in Texas. The other thing is, again, TB. It seems really aggressive without any immunosuppression, but I think in theory, all of these things are possible. Obviously has a predilection for the meninges, basilar meningitis, bilateral airspace disease, adenopathy, marrow involvement. This would be profoundly disseminated either tuberculosis or of a dimorphic fungi. And then the fungus that like sneaks in under the radar that we don't really think about in immunocompetent people, but can cause bad disease in immunocompetent people, that's found everywhere, is actually Cryptococcus. So I think every time I think of the endemic fungi, I just make myself remember Cryptococcus also, and that one doesn't really have that much of a geographic predilection. So then you move your way up, and now she has spent a lot of time, and we heard about rat exposures, and rats come with rat urine, and Leptospira lives with rat urine. Leptospira, we'll examine her in a bit, kind of, or at least Weil's disease of disseminated Leptospira can manifest with conjunctival diffusion, jaundice. It presents with diffuse alveolar hemorrhage and respiratory failure, renal failure, and hepatocellular injury. So again, still very much could be in play depending on that with that epi. Those would be things that I'm thinking about. The turkey farming, man, I trying to think about, so she wasn't around mammal placenta, so that's probably not things like Coxiella. But I'd have to kind of go through, you know, when I think about that much bird, again, I think back to stuff like crypto, and I think back to stuff like histo, neither of which we've treated, and she got worse. So something that I actually haven't mentioned thus far is you actually have a lot of data already from the preceding hospital. And so I think CSF cultures and the hopefully litany of blood cultures that she underwent may also be useful. But with this epi and somebody that's this sick, I'm going to be starting to thinking about histoplasma urinary antigen. I'm going to be thinking about trying to get an actual respiratory sample. When she's intubated, I think that'd be a lot easier, and sending it for both fungal culture as well as AFB smear and mycobacterial culture. Mycobacterial cultures on the CSF, fungal culture on the CSF, a serum cryptococcal antigen. You're thinking about, because she's super sick and we're obviously not treating something here. So whether it's a sterile process or one of these cooler infections, I don't know yet. But those are the things that kind of pinged in my head with that really rich social and migration and exposure history. I think I'll pause there. There's a lot of data that I want, but that kind of, this is why a social history is so important. The only other thing with the rat exposures is rat bite fever, which is Streptobacillus moniliformis. Usually comes with a rash, but they can get super sick, have high fevers, and have multi-organ failure too. So so I was flirting with the neoplastic and autoimmune, but that aliquot really makes me think we got to do a little bit more work before we're ready to call it HLH from lymphoma or HLH from some autoimmune disease.
That was awesome. I love at the pearl that if TB can cause anything, histoplasmosis can do better. I think will be something that I will remember. Mark, can you give for us the physical exam?
Yeah, now I'm going to move on to physical exam and then just basic labs. So when I met the patient, so the patient was intubated, sedated, and paralyzed. On HENT exam was notable for scleral icterus. Cardiovascular exam, I'll just highlight her hemodynamics. She was on norepinephrine, a medium dose of norepinephrine and vasopressin as well. For her pulmonary exam, but didn't appreciate any murmurs, I should say. On her pulmonary exam, just heard mechanical breath sounds, some crackles at the bases. At the time, she was ventilated with an FiO2 100% and a PEEP of 15. On abdominal exam, nothing notable on abdominal exam. On her extremities, she had 2+ peripheral edema. And then her skin exam, I didn't appreciate any rashes, lesions, ulcerations. And then on her MSK exam, there was no evidence of synovitis. And moving on just to basic labs, I'll kind of give the outside hospital labs and then the labs that we got on the first day of admission in the MICU. So her complete metabolic panel, this is 10 days prior to transfer at the outside hospital. She had a sodium of 131, and this is just for comparison, a potassium of 3.1, a bicarb of 19, an anion gap of 14, a BUN of 7, a creatinine of 0.8, an AST of 58, an ALT of 58, an alk phos of 193, a total bili of 1, and a total protein of 7.8. Upon arrival to our MICU, she had a
Is
sodium.
there a globulin on that, Mark? Do you know by chance?
Yeah, sorry. So a albumin of 3.5, with I guess the globulin then being the
7.8 minus 3.5.
And then the complete metabolic panel in our MICU was a sodium of 140, a potassium of 3.8, a chloride of 104, bicarb of 25, anion gap of 11, a BUN of 62, creatinine of 2.98, an AST of 187, an ALT of 60, an alk phos of 75, a T bili of 6, a direct bili of 4, with an indirect bili of 2, a total protein of 4.9, and an albumin of 2.4. Her CBC and coags at the outside hospital 10 days prior to transfer was a white count of 13.6 with neutrophilia and lymphopenia, a hemoglobin of 11.3, platelets of 236, and normal coagulation studies. And then upon arrival to our MICU, she had a white blood cell count of 2.3 with lymphopenia, a hemoglobin of 6.3, platelets of 23, and normal coagulation studies. And then she had a haptoglobin that was less than 30, an LDH of 689, a retic count of 34,000, 1.3% retics, a ferritin of 1,300, a direct Coombs positive for IgG, an HIV that was negative, and a UA that was bland.
All right. And that HIV was an antigen antibody, presumably
Correct.
like 5th generation test. Okay.
Correct.
Okay. So a lot of data there. Again, the thematics here, she's getting sicker, right? She now has multiple organs that have failed, and she's developed sort of, again, marrow involvement, renal involvement. We talked a little bit about that. She has sort of hepatic involvement. She has a hypoproliferative anemia with a large amount of, with, you said 1.3% reticulocytes? Okay, so which presumably is an inappropriate response or a hypoproliferative anemia, suggesting that pancytopenia may be actually not due to sequestration or destruction, but rather due to a productive thing. The LDH being that high is tough, right? We all like to think of it as the lymphoma detecting hormone. That's what LDH stands for, right? But it's actually, you know, she has diffuse alveolar injury. She's got red cells that are turning over. She's got, you know, all these things. So does it make us have to consider lymphoma? Totally. But like just bad pulmonary injury will give you that. Hemolysis will give you that. So did we have a CK at all or anything like that with the myalgias?
CK was normal.
CK was normal. Okay. All right. And then we see that she has kind of progressive hepatocellular hepatitis with, you know, significant conjugated hyperbilirubinemia as well. So I think kicking around things that I'm worried about, this does, you know, she has an elevated ferritin, albeit not like HLH elevated. Does she have triglycerides at all?
The triglycerides were normal.
Triglycerides were normal. You know, she's got a lot of stuff going on. I'm wondering, you know, some of them do argue for HLH. Others just argue for kind of like unchecked inflammation that maybe doesn't meet HLH criteria, though. Again, with fever, altered mental status, pancytopenia, organomegaly, all of those things kind of do sing the kind of HLH. As far as the Coombs goes, the Coombs being positive, you know, is this an actual warm auto? Really hard to say. That bili is mostly direct, which does suggest that the liver is actually involved, as opposed to the bili being kind of due to unchecked autoimmune hemolysis. But sometimes that can be kind of a marker of autoimmunity with things like lupus. So I need a lot of micro before you can convince me to immunosuppressor. Was there any kind of evolution in imaging studies between the initial hospital and yours?
Since she got a CT chest a few days before the transfer to our hospital that showed the bilateral airspace opacities, bilateral hilar lymphadenopathy, we didn't get a repeat CT chest right off the bat.
All right, and so thus far her treatment course was initially vancomycin, piperacillin, and tazobactam. Later on, she was broadened. There was an addition of doxycycline and azithromycin as well.
And ampicillin as well.
And then ampicillin as well. All right, but no acyclovir?
And acyclovir, sorry, I should mention.
And acyclovir, okay, all right. And she got worse again on that, which is ultimately why she prompted transfer to you.
Correct.
So what are we missing with that many antimicrobials, right? Doxy will get you, well, it's not perfect babesia treatment. It will have some kind of partial leptospira treatment. Same thing with the beta-lactam will have some degree of leptospira treatment. The azithromycin should be treating Legionella, which is again, also we mentioned was on the list. And then the rarer stuff, I'd honestly have to look it up, but I know that we're not treating fungi and I know that we're not treating tuberculosis. So like I said, I'm going to need a lot of microdata to talk me out of with that epi to talk me squarely into the into worrying a little bit more about lymphoma, worrying a little bit more about an autoimmune disease that's manifesting with all of this. So were there like CSF and blood cultures and different fungal studies and all that? Because if there's not a way to identify the pathogen this way, then we need to go get tissue and we need to go into the lungs as well, because there's just a lot of stuff that's going on here.
Yeah, the next aliquot will have a lot of micro studies.
All right.
And if I could,
sure, go ahead.
Oh no, you go.
No, I was going to say sort of just there's a lot of stuff that we can send, but it's very useful to kind of think about what is likely based off of her epi and then test based on that. So again, we kind of went through the more esoteric pathogens and I would direct testing towards those.
Awesome. And if I could borrow the lymphoma detecting hormone on rounds, I would greatly appreciate that. That is awesome.
That's from my chief resident, Sawala Guse, when I was a senior resident. So I stole that from him. I got to give credit where credit is due.
Okay, so next we're going to talk about a lot of labs. And again, I'm going to keep this authentic to how the data was coming into me. So some labs that came back from the outside hospital and then labs that came back at our institution. So I'll start with the outside hospital. So she had an ANA that was negative. She had a chikungunya, IgG and IgM that was negative. She had an Aspergillus fumigatus antibody that was negative. She had a beta-D-glucan that was negative. She had a dengue fever antibodies that were negative. She had a quantiferin test, which was negative. She had brucella, IgG and IgM that was negative. She had a COVID, which was negative. She had a mycoplasma pneumonia, IgM and IgG. The IgM was negative and the IgG was positive. She had a MRSA that was negative. She had EBV antigen IgM, which was negative. She had a leptospira IgM that was negative. She had some enteric pathogens that were negative as well. A respiratory viral panel that was negative. She had hepatitis serologies, Hep B, Hep A, Hep C, which are all negative. She had a Lyme IgM, IgG, which was negative. She had an Ehrlichia, Anaplasma, Rocky Mountain Spotty Fever that were all negative. She had a Chlamydia psittaci antibody, which was negative. And then she had a meningitis encephalitis panel. I believe this was a biofire from the outside hospital that was negative. And this was testing for E. coli, H. flu, Listeria, Neisseria meningitis, Strep agalactiae, Strep pneumo, CMV, enterovirus, HSV1, 2, HSV6, VZV, and then crypto as well.
And that was drawn off the CSF. That's
Correct.
the BioFire fancy next generation. That's so many things.
The only things that were positive at the outside hospital, she had a Coxiella IgG that was positive to 1 to 23, but an IgM that was negative. She had a CMV IgG that was positive, but a CMV IgM that was negative. And then moving to some labs from our institution, she had blood cultures that were negative, respiratory cultures from a tracheal aspirate that were negative, or cooking, I should say, to date. A strep pneumo antigen that was negative. She had also arbovirus panel from the CSF that was negative, a cryptococcal antigen from the CSF that was negative, a strongyloides IgG that was negative, a urine histoantigen that was negative, and a plasma histoantigen that was negative, Legionella urine antigen that was negative. She had blood parasites that were negative, and then malaria was negative for antigen detection. And then the next aliquot will reveal the final diagnosis.
All right. Remember when I said I'm going to need a lot of micro before I'm convinced that this is probably not an infection? I would say what is still on the table. For disseminated disease, the urinary antigen and histoplasma is actually a really, it's a pretty decent test. So this would probably be disseminated disease. And the question is, disproving tuberculosis is exceedingly difficult. So the one thing I haven't entirely been convinced of is that this is not refractory disseminated tuberculosis, which can sometimes manifest this profoundly and this devastatingly. And she's worse, and it's the one thing we haven't treated for. It's the one thing on the test that you know can technically give you this this lymphocytic meningitis, the respiratory failure. The kidney injury is kind of tough to suss out, but there is involvement of the reticuloendothelial system. So if this isn't something like lymphoma, then I really do have to think that this is something that would suggest TB. Now, lymphoma very well could do this, and it's actually can be a really tough diagnosis. Things like intravascular lymphoma are notably difficult to diagnose, and they can manifest with like sort of HLH and all these things. This is a really tough one because the treatment for lymphoma is, you know, profoundly immunosuppressing, but it is potentially life-threatening or life-saving. As far as autoimmune diseases, like what's left on the differential diagnosis, adult onset still disease, you know, can present with leukocytosis, which she had initially. It can also present with arthralgia and sore throat, and then degenerate into what's called macrophage activation syndrome, which technically this kind of meets criteria for. Lupus, I think there is, in my opinion, and many other rheumatologists would share that seronegative lupus is not a thing. And so with an ANA that's negative, that like pretty comfortably kind of puts lupus pretty low on the differential. So autoimmune diseases that could do this, I guess, you know, in theory, we have to think about adult onset still disease. She did have arthralgias. I don't know if she ever had a cough or a sore throat. She did have that leukocytosis. We haven't heard about a rash. Again, the ferritin isn't like crazy high. TB itself, if I didn't mention it earlier, can cause HLH too. So yeah, so I think I still need to see some AFBs. I still need to see some mycobacterial cultures. The easiest ones to go for would be the lungs as a great place to start. And then we are probably going to need more advanced diagnostics at this point. So the question is, what do we go for? So the targets would be the mediastinal lymph nodes, which wouldn't be able to give you an excisional biopsy. And she didn't have any other adenopathy on exam or any other easy place to do an excisional lymph node biopsy. So then that leaves you with biopsying the liver, which is kind of risky, or biopsying the bone marrow. So again, I would probably go look for in the lungs at least signs of pulmonary tuberculosis first, via tracheal aspirate or bronchoscopy with all the secretions, getting an AFB. You know, if it's a skilled proceduralist doing the bronchoscopy, the one thing would be to get a chunk of the mediastinal lymph nodes while they're in there and send them. I guess lastly, one other thing, whenever you're thinking about TB and lymphoma, sarcoidosis is something to think about, which we really haven't mentioned. This is really rip-roaring for sarcoid. There are subvariants of sarcoidosis that can involve the liver. It's called, uveoparotid fever, or there can be just really aggressive sarcoidosis, but this would be on the rarer side for how sarcoid can behave. But I guess whenever you're thinking about TB and lymphoma, sarcoidosis kind of has to make it into the differential diagnosis. Bone marrow biopsy with that degree of pancytopenia is probably, I think, a high yield test, higher yield than a liver biopsy. So bone marrow biopsy, I think, could be instructive both because you can get AFBs, mycobacterial cultures from it, but you can also, in that case, see any evidence of hemophagocytosis or any evidence of lymphomatous infiltration. So one thing, did we ever have a smear for the pancytopenia?
So the smear showed no schistocytes and some rare spherocytes. Sorry, I meant to mention that earlier.
Spherocytes. Okay.
No
so
blasts.
There's no early forms, no teardrops, no nucleated reds, nothing like that. No bands, anything like that.
Nope.
All right, just some spherocytes. Again, that IgG positive. Does she have some component of a warm auto being triggered by all of these different things? Again, I don't think it's lupus with negative ANA, but in theory, all these other lymphomas can trigger a warm autoimmune hemolytic anemia. So that's my thought process. I'm leaning, rule out TB before we immunosuppress her for either an autoimmune process, number one of which would be still disease, less likely to be sarcoid. And then I would also kind of think that this also is a pretty significant case that could be an advanced aggressive lymphoma. But we need some data, I guess. So I'd go for the lungs first and then a marrow second. And I don't know if that's where we're headed, but that's what I would do.
And the lungs is exactly what we went for. So on MICU day 5, so this is total hospitalization day 14, including the outside hospital stay, she got a bronchoscopy, and the BAL showed a red blood cell count of 36,000, a white blood cell count of 934, primarily lymphocytes. And then the patient also got cytopathology that showed that was negative for AFB and then TB PCR, but showed small budding yeast and a background of necrosis with acute and chronic inflammation, and reactive and degenerated epithelial cells were also present. And the stains and morphology were most consistent with histoplasmosis.
Wow, with a negative urinary antigen. Wow. So we, just a great reminder of diagnostic tests. So the classical teaching is that with disseminated disease, the urinary antigen is actually well positive. And the other point is that is that I guess sometimes they don't have a high enough titer in the urine to actually catch the histo. So just to think about, I think reflecting on this case, as we think about it, we mentioned it early, and the diagnostic testing kind of put it on our back burner. This did scream either a mycobacterial infection or an infection with a dimorphic or an endemic or ubiquitous dimorphic fungus. So that is a heck of a case.
Thank you so much, Mark, for presenting this case. It was really great. Do you have any thoughts that you learned with this case?
Yeah, this is one of my favorite cases of residency. And it was, my first day in the ICU as an intern, and my mind was just spinning. I had, no idea where to start. And like even just like learning the terminology in the ICU, everyone was saying this thing called Levophed. I thought they were talking about Levaquin. Like I just had no idea what was going on. And really, I think on day 2 is when I'm like, all right, let's take a step back. Let's really think, deeply about this case. And something that the clinical problem solvers talk about all the time is that when there's so much going on in the case, so many positive data points, is try to latch on to data points that have the smallest differential. So I think something that stuck out to me is that the prominent bilateral hilar lymphadenopathy in the beginning without really prominent parenchymal like lung findings, the hepatosplenomegaly, and the pancytopenia. Those three things for me really were like, all right, this is either infections wise, exactly what we mentioned, TB, endemic mycoses, autoimmune disease, sarcoid, or cancer lymphoma. So I think after I kind of thought about that and like, just like, we were talking about pretty quick progression for sarcoid and lymphoma. So I really then, wrapping in her social history and her travel history, I think this case, definitely on Monday morning quarterback too, histo or mycobacterial infection, I think fit well in this case. I'll say the one thing though that we, this patient had severe disseminated histo and was presumably immunocompetent, which is, extremely rare. And we actually sent some blood samples to the NIH to see if she's had some sort of immune defect in, the interferon gamma or TNF alpha pathway that would lead her, predispose her to an increased risk of disseminated histoplasmosis. So yeah, this case will always, always remember this case, so much learning. And the patient, I'll say, is doing well. Received a prolonged course of amphotericin and then switched to itraconazole and steroids as well. I would say it was amazing. As soon as we started amphotericin and steroids, the next day she defervesced, and then her oxygen requirements improved. And she was intubated or extubated like 2 days after we started amphotericin when she was in florid ARDS. So it was truly an amazing case for us. Great discussion.
It's a wild case.
You're going to
teaches you where to, kind of go where the money is, right? She had profound respiratory failure. She had alveolar filling disease. Certainly the money was in the bronch. And again, remember, just because it's, you need to start thinking about the more sinister things, but when things like, I guess sinister in the sense of like something like a lymphoma, when the treatment is so potentially dangerous for the other stuff on the differential, that has to be the place that you start. And so being talked out of, I couldn't entirely commit to start even considering the other stuff until we really looked for an infection in the lungs. And if the lungs hadn't given you the answer, then you kind of got to go for tissue somewhere else. So I'm glad that they gave you an answer right then and there. Certainly a great reminder that one is you're only as good as your tests, right? And so not to get totally swayed by the fact that the histourinary antigen was negative. Two would be the fact that it was all in the epi, right? It was all in the exposure history, and that you may not presume that a 38-year-old would be coming in this hot with histoplasma, but until you change the narrative and you kind of take that history, and all of a sudden her substrate and the substrate of problem representation changed drastically. So that was a fantastic case.
Thank you so much, Dr. Restrepo. We always like to have you here with us. We are big fans of your discussions. And Ibrahim have done some teaching points if you want to tell us more.
Sure. Thank you, Dub, and thank you to Mark, and thank you to Dr. Restrepo for this amazing case today. So I think this was an extensive discussion, so I'll try to summarize at my best. So upon hearing that this patient was presenting with subacute and acute constitutional symptoms, you have to think about viral infections, but also suspect otherwise if it has been going on for weeks. This widens the differential to include things like autoimmune disease, malignancy, drugs, as well as endocrinopathies, as well as other etiologies that might result in constitutional symptoms. Again, the patient was also presenting with headache, myalgia, and fever, and you need to approach each of these separately. So when you think about headache, you have to make sure that it's not at the center, because sometimes headache can be at the center, but sometimes can also be non-specific. And then for the myalgias, they often arise secondary to an inflammatory response. So you can also think of them as non-specific. However, for the fever itself, here's when history becomes very important, where you have to consider the tempo of the fever. And then you also have to consider the host status itself. Has this been someone who's been traveling? And you also need to consider their immune status. If they're, for example, immunocompromised, this widens the differential to include parasitic, fungal as well as tick-borne infections. And then we heard that this patient had acute renal failure. And then for a patient who's developing acute renal failure after receiving peptazo as well as vancomycin, you can think of it as a side effect. But you also have to think about multi-organ infections. And then for bacterial sepsis, we heard that this patient had a fever, but they weren't tachycardic upon presentation. And so usually bacterial sepsis would present with tachycardia with fever, especially if they're young and healthy. However, there are exceptions that you need to consider, including typhoid. And here's where travel history becomes important. There's also Legionella, Leptospira, as well as other intracellular pathogens. And then for reticular endothelial involvement that this patient definitely had, as well as pancytopenia, you also have to think again about tick-borne infections, anaplasma, babesiosis. However, if the patient received doxycycline, just like our patient did, and they were not becoming better, you need to think about HLH, as well as autoimmune causes, including adult onset Still's disease, lymphoma as a malignancy, and then as an autoimmune disease, again, SLE. And then you also have to consider the host and the tempo, and them not being responsive to treatment, because this lowers the pretest probability, as we've mentioned, of bacterial infections. And then for a travel history for someone who's coming from Central America or Texas, you have to think of TB, histoplasma, plastomycosis, as well as other dimorphic fungi. And also you have to keep on your mind cryptococci, especially if they're immunocompetent, and especially considering the fact that cryptococci does not have a predominance at a certain geographical location. And then we heard that this patient had some rat exposure. So when there is rat exposure, think about rat urine, which can result in leptospira, which seemed to fit this patient's presentation with the respiratory failure and the renal failure. However, you also have to think about streptobacillus. And then if this patient had exposure to mammal placenta, you need to think about something like Coxiella burnetii. For the workup of such a patient with a similar presentation, you have to consider an extensive workup, but focusing specifically on histoplasma antigens, serum cryptococcal antigens, as well as respiratory cultures for fungal infections. And then if the treatment is non-responsive and the lab data do not fit one diagnosis over the other, you have to consider tissue biopsy as well as microbiology. And then it's very difficult to rule out disseminated TB, which can also result in HLH. And then lymphoma is also difficult. And then adult onset Still's disease would also be difficult to rule out in such a patient, as well as sarcoidosis. So we need to go for further workup in this patient, as we've mentioned, focusing specifically on the mediastinal lymph nodes for biopsy as well as culture. But also you need to consider liver biopsy and bone marrow biopsy. And the bone marrow biopsy would be particularly important alongside the lung biopsy, because you can do AFPs, TB cultures, and it can also show you if there is hemophagocytic lymphohistiocytosis. So I think that's all for the TB for today.
Thank you, Ibrahim. I didn't even know I said that many things. So appreciate you summing it up so beautifully.
Thank you so much, Ibrahim, and thank you so much again, Mark and Dr. Restrepo. Thank you, Shema and Ricardo, for scribing. This was an amazing session, and I hope to see you all tomorrow.
I think it's really good that I turned the AC down, because I was sweating. I was sweating that case.
Bye, everyone.